Good evening, friends, and welcome back to the Thursday Clinics live webcast from LTMMC Sion Hospital, Mumbai. We once again thank the authorities at Sion Hospital, Dr. Radha Gildial, Madam, Head of Department, and the Dean for allowing us the facility for this live webcast. And we also thank Alchem Alpha Max for giving a scientific grant to facilitate this. Today we have a case discussion as usual, followed by a small discussion on a topic which can be useful to students. That's approach to inborn errors of metabolism. That will be done by Dr. Amdekar sir after the case. We start with the case first. Dr. Rutuja is presenting the case.
Good evening, everyone. So we start with the case. 1 year, 11-month-old girl, second by birth order, born out of non-consanguineous marriage, Rathod by community, Hindu by religion, hailing from Nashik, informant being mother, reliable, brought with complaints of fever for 1.5 months. Child was apparently alright 1.5 months back when she developed fever, which was insidious in onset, high grade, documented, continuous in nature, having 2 to 3 spikes per day, not associated with chills or rigors, not associated with any rash, subsiding temporarily on medications, and child being active during the interfebrile period. For the above complaint, child was taken to a local private practitioner and was given some oral medications on OPD basis for 5 days. However, the fever did not resolve and the child was admitted to the hospital at the native place, Nashik, on 1st January, where some blood and urinary investigations were done and was told to have some infection in the urine. Child received injectable medications for 7 days and was discharged. However, fever did not subside and child was readmitted at another hospital from 7 Jan to 15 Jan for a period of 9 days, where she received injectable medications, and one another hospital from 18 Jan to 22nd Jan for a period of 5 days, where again blood and urinary investigations were done along with some radiological investigations, and child received injectable medications for 5 days. Child then presented to our hospital on 9 Feb in view of persistence of fever spikes. During the hospital stay, child had continuous high-grade fever, which was documented with 3 to 4 spikes per day, which was subsiding temporarily on medications. There is history of irritability with decreased oral intake during the febrile period. There was no history of cough, cold, or any increased respiratory activity. No history of loose stools, vomiting or diarrhea, or any abdominal pain. No history of ear discharge, altered sensorium, convulsions, or neurological deficit. History of animal contact is present since 2 to 3 months. The animal being a neighbor's cat with whom the child used to play. No history of any cox or cox contact. No history of crying during micturition or decreased passage of urine. No history of bleeding from any sides. No history of joint swelling or bony pain or reduced movements or any rash. No history of significant weight loss. No history of any recent travel. Past history, there is no similar complaints in the past. No history of any recent medical or surgical illnesses. No history of any blood transfusions. ANC wise, not significant. Birth history is full-term normal vaginal delivery. Birth weight being 2.75 kg. Cried immediately after birth. Birth vaccines were given. There is no history of any NICU stay. Discharged on day of life 2. Immunization history wise, the child is immunized till date according to the national immunization schedule, and developmental wise has achieved all age appropriate milestones in all 4 domains. Dietary system wise, child was exclusively breastfed till 7 months of age, after which complementary feeding was started. Right now, the expected calories of 1100 with a deficit of 420. Proteins expected is 12, the observed is 7 grams with a deficit of 5. Family history wise, no significant family history. Socioeconomic wise, the child belongs to lower socioeconomic class.
Okay, so So, I mean, the chief complaint is fever, and probably that's the only complaint, right? So let's start with some basics. Tell me, what does each of these words mean to you about fever? We describe fever with so many words. What do they mean to us? So let's start with insidious in onset. What does insidious in onset actually mean? When will you call it insidious in onset?
Pinpoint the time at when we cannot exactly pinpoint at when the fever started.
Very good. Okay. So now, what would that mean to you? So which fever cannot be exactly pinpointed? High fever or low fever? Low fever, right? So if it is high fever, then it cannot be insidious in onset. Okay. So that's a kind of a correction that we have to do, right? It is only low fever which will be insidious in onset. Then high grade. So what does high grade fever mean to you? What is the interpretation? Because otherwise, what's the point of asking all this? Come on, very simple questions, but maybe we've never given a thought to all this.
Sir, it depends upon whether this high grade fever was on day one or whether it was gradually it increased. If it is on day one, usually we can think of viral fevers which usually have high grade fever to start with, whereas bacterial usually take time to develop.
So partly you are right that the interpretation will differ on which day of the illness the fever is high, but suppose I start with acute tonsillitis, can I get high fever on day one? Suppose I start with UTI, can I get high fever on day one? So high fever on day one doesn't always mean viral. Viral is one option, right? So on a broader scale, what does high fever mean? Then we'll come down to how to decide viral or bacterial.
Sir, infective cause. Infective cause.
So again, infective cause is a assumption because very arbitrarily 90% of fevers will be infective. Just arbitrarily I am throwing a figure. But whoever has a non-infective fever also has fever of day one on day one, right? 1 month fever non-infective. But on the first day of the month it was also non-infective, no? So high fever doesn't mean infective or non-infective. So in terms of physiology, what does high fever mean?
If the fever is associated with reduced activity or in the interfebrile period also the child is not active, then it will be significant. Point
Correct, you are right, but we need to understand the reason behind it. So what causes fever? Let's go down to that.
Sir, inflammatory response in the body will cause.
Okay, inflammatory response of the body to.
Could you have a without inflammatory response? You are right, mostly. Any other way the fever comes without inflammation?
It can be a metabolic fever also. Like due to increased basal metabolic rate, hyperthyroidism.
Hyperthyroidism.
Sir, if there is any hypothalamic lesion also, then.
So hypothalamic lesion, central fever.
Heat fever, drug fever, autonomic nervous system fever, so many types of fever. So you are right mostly, but now tell us how to go further on that.
So broadly we said that inflammatory response of the body to a injurious agent. Okay, that agent can be anything. Okay, so if I get burns, I can get fever due to that also. So some injurious agent, right? Now, how will you further go into physiology to say who will get high fever? So what do these inflammatory response, what does it do? What is released and what do they do?
Interleukins.
What do they do? How does it translate into fever?
So cytokine storm.
Cytokine storm. Okay, don't use the word storm, but cytokines are released. Then what do they do?
Trying to eliminate the foreign agent.
Okay, that is one function. What else?
Hypothalamus. These inflammatory mediators reset the hypothalamus.
Very good. So they reset the hypothalamus, and that is why you originally get fever, right? So now if you have to loosely correlate, this may not be very perfect correlation, but if you have to loosely correlate small number of release of cytokines, small fever, and high release of cytokines, high fever. When will small number be released? When the injury is small or when the injury is big? Small. So first logical response is that high fever would mean a large amount of injury. Now this large amount of injury can be in two ways. It could be a big injury at one spot. Example, acute exudative tonsillitis. So massive severe inflammation but at one spot is high fever. Or a viral infection where I have a rhinitis, a pharyngitis, a body ache, a myositis, a gastritis. So small inflammation at 10 places, all adding to 100. So that is another way I get a large amount of cytokine release. So that is what causes high fever. So this is the concept to understand. So high fever going backwards would mean in small inflammation at 10 places or big inflammation at one place. Is this clear so far?
Absolutely, Rajesh. I wanted to ask a reverse question. You know, he has taught you the rules, so I have to ask you for an exception. So which condition would you not get fever? So what are the situations or conditions where there is suppose an infection, but fever is not there? Think some particular age group, some particular situation where you have infection but no fever.
So neonates.
Neonates, very good.
And in immunodeficiency.
Immunodeficiency, or more like immunosuppressive agents like steroids. That's why we say if you're given steroids, you may not mount a fever, right? So that's where exactly you have no cytokine release or low cytokine release. But what do you mean by high grade? Means I'm asking for a number.
Yes. So that's the other thing. So high grade, is it any particular number?
When will you call it?
Greater than 38.5.
That is fever. What is fever?
Sir, a parent would tell me it is a high grade.
Figure. Number. You're measuring now, no?
See, parents have this habit of saying my child's fever shot up from 98.9 to 98.10. Okay, so that not necessarily is high fever.
So roughly more than 102.
102, correct. So 102 translates into 39 centigrade, and 40 is 104, roughly speaking. Yeah.
So now coming back to, we were saying interpretation of each word. So when the parent or when your history tells you that this...
Sometimes it's relative. For a newborn, 102 is also high. For us, 104, 105. For a newborn preterm, 102 we will not call low fever, that's high. So you take it into consideration the age and what's the resistance that you expect from the child, and then so high may be high for somebody, not so high for others.
So when we get a history of high fever, how should our mind start thinking that this is either small inflammation at multiple places in the body or big inflammation at one place in the body? That's how you should start thinking. Small inflammation at multiple places in the body is either viral or non-infective inflammatory. and big inflammation at one place in the body is bacterial, right? Now the next thing that you have to think of is how to decide bacterial or viral. So big inflammation at one place is usually at the site of entry of germs. So when germs enter the oropharyngeal tract, what is the commonest infection? Tonsillitis. If germs enter through the GI tract, commonest site of infection is dysentery or UTI, site of entry and infection. All these infections localize early. So in 24 to 48 hours, you will get symptoms of where the infection is settled. You'll start getting throat pain, you'll start getting loose motions, you'll start getting urinary symptoms, etc. So next you start looking for that. And if that is not there, then you keep thinking whether the other option of small inflammation everywhere, which is viral or inflammatory, is a possibility. So that was about high-grade fever as a understanding. We'll get into more details a little later. What is the importance of documented or not documented? Simple. What is the importance of documented or not documented?
Whether it's fever in the first place or no, or are just the parents perceiving that the child is warm? And again, secondly, if you have a value, then the grade we can identify.
Absolutely. So for low fever, it's extremely important whether it's fever or no, and then the grade of the fever. Continuous in nature. So what is your understanding of continuous fever?
Variation less than 0.5 degree and without touching the baseline.
That's the textbook definition. Now, have you ever come across any individual in your lifetime in the city of Mumbai who has not taken antipyretics for fever? I have said city of Mumbai. Huh? I have not said the African Sahara Desert. So the question is that that's a textbook definition. What happens when you take an antipyretic? Does that definition hold true? So how do you fish out continuous fever in the presence of antibiotic taken? Clear my question? So how do you fish it out?
When the patient takes an antipyretic, once the effect of the medicine wears off, the fever again comes up.
Excellent. So that's your equivalent of continuous fever, right? Now what is the importance in terms of your analysis? So suppose it is discontinuous fever or it's continuous fever, what does it tell you? Does it tell you viral or bacterial? Or does it tell you anything else? Come on.
If it's not continuous, I've just got up to prod you guys because everybody is getting lethargic. More questions you answer, more we can discuss, correct? If it's not continuous, it is either intermittent or correct. So you have various patterns, right? So that's what Dr. Rajesh is asking. So if it is continuous, what does it mean? Viral, bacterial, and the mechanism. If it is not continuous, what it can be, whether there is no pattern at all or whether there is some pattern. And if it is no pattern, then it's erratic. If there is a pattern, then whether it is intermittent or how often it is coming.
Give us examples where you can clinically identify a pattern.
Malaria?
Intermittent fever, quotidian type.
Okay. So that's the classical description. So you would have alternate day or whatever. Now again, how many children, how many cases of malaria present with that type of fever, and why do they not present with that type of fever? What is the reason for that type of fever in malaria?
Suicides.
RBC lysis and release of that hemoparasites, during that time there will be fever spike, a height of fever spike will attain, because there is multiple multiple set of populations, different times it is getting released, that's why it is not commonly followed.
Excellent. So only when you have one particular set that is getting lysed at a particular time, you will get that pattern. So that's also not always there, right? So multiple populations lysing at different times, any kind of fever.
But you said quotidian, correct? So which condition more regularly says quotidian?
Hodgkin's.
Hodgkin's.
Hodgkin's is pale abstain fever. So fever will be there, then periods of afebrile period lasting for weeks or months, and then again fever spikes will be there. So that's pale abstain fever with type B symptoms, night sweat.
Any other non-infective condition which...
The last one which we discussed, juvenile idiopathic arthritis will have quotidian fever,
Systemic onset GIA.
So coming back to this continuous, so again, what we are trying to teach you is that what we have in books is right, but in practice, we will get only continuous, which means rhythmic, as soon as the effect of antipyretic wears off fevers back, or the only diagnostic fever is the erratic fever, which Tushar just talked about. So any day, any time, funny fever, and in between variable periods of no fever. If this fever is high, you might think of malaria, right? So that is one thing other than continuous. Otherwise, the whole bunch, bacterial, viral, everything can fit into that, where the effect of antipyretic wears off, fever comes back. Now, what happens in your inflammatory disorders? How many spikes a day? Classically described in SOJIA? 1 or 2. Okay? So that is again a type of a rhythmic fever. So here it's not because the antipyretic effect as worn off fever has not come back, but there's a rhythm of that fever of 12 or 24 hours. Right? So that is your interpretation of continuous or otherwise.
What is fever off and on? We have discussed all the types. We also talk about fever off and on. What is this off and on? Is disease off and on? Disease is on and fever is off and on. Any comments on that?
Come on.
In on and off fever, the disease process is ongoing, but the fever is not mounted every time. Like, or maybe like in tuberculosis, how there's an evening rise only and then there's no fever. So the disease process is continuous, but the fever is not always mounted.
So what you're right. What sir is, so you've said disease process is on only. So what sir is asking is two more things. What fever will you call off and on? So I'll give you an example. One viral fever in July and one viral fever in August end. Is it off and on?
Why? It's viral only, no? Both are viral URTI.
It was on, then off, then on. So is this off and on? What is off and on? That's what sir is asking.
Give an example.
Sir, when there's a fever of long period, which is not occurring every day, there's no particular pattern to it. But then, like in this example, we are seeing fever since 1.5 months. But I can't specifically point ki every day it's coming in morning only or evening only. Then I'll maybe say on and off fever spikes, where the disease is ongoing, but there's no particular pattern to the fever.
He's saying about one episode and fever. So.
Actually, off and on is off period for a day, 2 or 3. Short off period, but again and again. Okay, what he said about 1st July and the end of August is not a short period. It could be 2 different illnesses. But when there is a short period off, very likely the disease is same. And then you rightly said systemic inflammatory every 12 hours, 1 spike or 2 spikes. Why is that? In all other viral bacterial infection every 4 hours, 6 hours. Okay. Why in SOGIA you have 1 or 2 spikes? Any reason? That's the reason also of fever off and on. So what's common between these two? Why is 1 spike or 2 spike? Disease is on, no?
Because the height of the inflammatory response that the body is mounting, so in that period of time the fever would be manifested.
Any inflammation may have any episodic issues. Like, for example, a simple allergy. Let's talk about urticaria. Sudden disappearance, again appearance. So whenever the fever pattern does not relate to antipyretic, you start wondering whether it is non-infective inflammatory disorder. And another is, if the same thing is going on for a longer time, it's mostly non-infective. Though infection can go on also for a long time, right?
But you can also have fever which goes on for 2 or 3 days, then the fever settled and you got fever again. And we call that as what? Biphasic fever, right? So why? Give me 1 or 2 conditions and why.
Dengue, yeah, very good. Then, so even other viral fevers can have a biphasic fever, yeah. Why, Sushar is asking?
And leptospirosis can also have, right? What is the difference between other viral fever and dengue fever in biphasic fever, type of biphasic fever? You get my question? In dengue, the other virals also you have fever for 3 days. Dengue also you have fever for 3 days. And the child looking little better, and then the child gets fever again. How will you differentiate other routine, let's say respiratory viruses versus a dengue virus?
What is the difference in the second phase of fever? Come on.
Usually the second phase in other viral will not last more than 24 and the child will be comfortable. Okay, whereas in dengue, that's the time when you have all the complications of dengue. And same with leptospira, when you have a second immune phase, that's when the complications occur.
And I think in many typical viral infections it's biphasic, but the second phase is even shorter and of a smaller degree. Whereas if that second phase is something much worse, like a dengue coming with shock, or a hemorrhage, which means something getting worse, then you start wondering about. And why is this? A simple viral infection, my immune system acts, controls the virus, kills the virus. But for a day or two, I don't have fever, but the immune system feels there is still some virus lurking, so again makes a small attempt, and then finally I'm all right. But if that is not the cause, and if my immune system is unnecessarily working, the virus is gone, then it works so badly that I get into complications. So second phase has to be short and small. First viral infection, I had 3 days of fever, 102, 103. Second phase, 100 fever just for a day or so. Then I'm not worried. But on the other hand, I got better after 2-3 days of fever. I was all right for a day or two. And then the fever mounted high. I got sick. Okay. My appetite went away. I became drowsy. Oh, something serious is happening. That's how dengue, leptospira, multiple diseases do that. Right?
So now we discussed about continuous fever. But one adjective is missing. When we said continuous means we are talking whether fever came or did not come at all. But you may actually have fever which is continuing, but either it is decreasing, remaining same, or progressively increasing. That also part of the adjective that we would say, right? Progressive fever or improving over a period of time. So in first few days, how does that help you in making a diagnosis?
So worsening trend, improving trend, and same trend. We are talking of short fevers.
Short fever, first few days of fever.
Infections will usually be self-limiting, so they'll be progressive, means improving time. On the other hand, bacterial infections will be like worsening. same trend will be seen in inflammatory conditions.
Very good, very good. Okay, so we come back to this. So continuous in nature. So we said continuous only tells us that it is not erratic and not malaria.
Now, in this child, he has had 3 sets of antibiotics. Do you think the cause of this repeated fevers is simply a wrong choice of antibiotic, the wrong duration of antibiotic? Typical bacterial infection, not treated properly, sent home, came again, next time upgraded antibiotic, may work, may not work, again works partially. So do you think this is a partially treated bacterial infection? Every time they have changed the hospital, but the child was better, so discharged. I'm sure this is partially treated bacterial infection.
Sir, but with due course of time, it will localize to some.
Localization is such like a bacterial endocarditis, where there are no complaints. And there may be subtle signs, but they are not easy to pick up. There could be urinary tract infection. This child had no symptoms. You're right, localization, but there are bacterial infection without obvious symptomatic localization, right?
So, but over a few weeks, the child would have become more sick.
Partially treated, no? What is partially treated? Partially better. Okay. Give a thought, give a thought.
Sir, any associated complaints, symptoms other than fever? Any other associated complaints or symptoms will also?
And therefore, most important is the history of the first episode. If the first episode did not look like a bacterial infection, then this is not a partially treated bacterial infection at all. That's the importance of a long history of fever, where the first few days and the first episode gives you a guideline of what next you are expecting. This we did not expect that. Now we will have to see what urinary infection they saw. That's another story, right?
Okay. Now quickly coming to not associated with chills and rigors. What does it mean to you? So if it...
Use one word to answer. Use one word to answer. It means nothing.
Okay. Agreed, everyone is convinced that it means nothing. Can you get chills and rigors in viral fever? No, influenza is classically chills. Okay, viral influenza, H1N1 or whatever is classically chills. Okay, so chills and rigors have absolutely no meaning. It can be seen influenza, tonsillitis, UTI, typhoid, malaria, anything. And all of them can come without chills and rigors.
And malaria may not have rigors. UTI may not have rigors. Typhoid may come with rigors. That's why I said no interpretation, right?
No, not associated with rash. So what we are learning here is that when we ask these questions, there should be some interpretation in our mind. So when you ask this question, not associated with rash, what does it mean to you? What rash were you looking for? Suppose it was associated with a rash, how did it change your thinking?
Dengue can be presented with rash, or any inflammatory conditions like SLE also can be associated with fever with rash.
Okay. So you will have to divide in your mind a short fever from a long fever. So rash of a short fever from a rash of a long fever. That is one thing. Secondly, if you are looking at systemic inflammatory disorders, you are looking at a transient rash, evanescent rash. So you have to ask specifically, okay, when the fever rises, do you see some kind of a rash on the body which disappears when the fever disappears? That is something, if you get a very good history, it is very useful to you to diagnose that subset of fevers, right? Okay. Fine. Then after that, all this. So that, as sir has said, that this was treated with multiple. So now what are your thoughts? What could this whole story be? Is it a viral infection? Why?
duration is very prolonged.
One is duration. Two,
High grade fever.
high to we said, no, viral starts with high grade fever.
Continuous high grade.
Better reasons.
No
Okay.
viral prodrome features with any.
Okay, so I'll give you clues. What are the differences between viral and bacterial infections? We are changing track, but I'll bring you back to this earlier question. Differences between viral and bacterial infections.
Toxic looking sick child. Died.
Okay. Okay.
Systemic involvement.
Okay.
Signs of systemic involvement.
Okay. What I was looking for is viral infections are generalized, bacterial infections are localized. So that's one important big difference. So here in 1.5 months, there is only fever and nothing else. That's very unlikely of a viral infection, besides 1.5 months and all that, right? Okay. Can it be a bacterial infection? Sir already said that partially treated bacterial infection. Can it be a chronic infection? Which chronic infection are you thinking of? Tuberculosis, okay. Anything else? Brucella. Anything else? So, enteric fever. So, is enteric fever on a possibility at this stage? Dissect it further. Upfront, yeah, you start thinking, but then do you have points for against enteric? Anybody, you all yourself, tell us.
Means only the chronic duration of fever. There are no other symptoms. Enteric would have had some other symptoms also associated.
Anything else in enteric? So this is too long a duration for enteric. So in the olden days, enteric was believed to be said that, you know, even if you don't treat, it will get better in 3 or 4 weeks ultimately. So too long, no complications yet, no big gaps in between, etc. So therefore enteric is unlikely. What about tuberculosis? Is it a strong possibility, weak possibility? Why weak? Answer.
In tuberculosis, there is a low-grade fever with constitutional symptoms like weight loss and decreased appetite, all that.
So to that, the question is, can tuberculosis give rise to high-grade fever? Yes. So now tell us which situations tuberculosis gives rise to low-grade fever and which situations high-grade fever.
Come on, we discussed, no? Who gives high fever?
HIV is positive.
HIV is positive.
It will give rise to a low grade.
Mike.
It will give rise to a low grade fever.
Why?
Because immunodeficiency state cannot.
Correct. So give us other conditions which in immunodeficiency states one gets what type of tuberculosis? Those will have low grade fevers.
Miliary tuberculosis.
Disseminated.
When have you seen high fever in tuberculosis?
CNS TB.
CNS TB. CNS TB is because there are 1 million TB germs there, or it is because there is a inflammatory response due to what? It's a immunological response to the infection. So whenever TB clinical manifestations are because of an immunological response, it will be high fever. And when the manifestations are because of the infection itself, it may be low fever. Right?
Pleural effusion is one more condition where one will have very high fever, TB.
Okay. So we discussed TB here and you said that less chances. So what are we dealing with possibly? What are more likely here?
Any deep-seated abscess.
Okay. So now tell us points for and against deep-seated abscess.
So it will have high-grade continuous fever, and it is sometimes it is difficult to localize.
Okay.
So the localizing symptoms could be absent.
So what is the characteristic of any abscess? Pain.
Yes.
So I think, over 1.5 months, it should somewhere, somehow come out with the pain.
Sir, amoebic or a parasitic infection we can think of.
Where?
Like in liver abscess.
Okay, so liver abscess is that same category of abscess. Okay. Anything else?
Malignancy.
Malignancy, okay. So again, immune-mediated fever, where the original trigger for the immune-mediated is malignancy. Okay. Sir?
I think we have said this again and again. When we talk about immunological responses, we need to be clear about 3 types: immune deficiency, autoimmune or infection-induced immune, which are immunoreactive, and immunodysregulated, that is malignancy. All 3 look alike, all 3 could be overlapping with each other, like you have an HIV with Burkitt's lymphoma. You have a tumor there, malignant, and you have a deficiency also. So when we are talking about immune response, we are talking about immune deficiency, immunoreactive of 2 types: infection-induced, autoimmune, and immunodysregulation. Right?
Okay. Go ahead. Anything more in the history?
On the chat box, Dr. Palniraman is active and he is giving his replies. Appreciate.
So the child being active in the interfebrile period, so how does it explain? Like bacterial infection should have a sick child throughout.
Yeah, so we forgot to discuss that. So why are we talking of activity in the interfebrile period? Why are we not talking of activity in general?
So the child was less
No,
active.
first forget this child. First let's understand the concept. So why do we use this question, okay, between fevers, how is the child? Very good. So at the height of the fever, child, you, me, everybody will be inactive anyway. So that is because of the height of the fever. So what you want to ask is that when the height of the fever is eliminated as a variable, when the fever is not high, if you are still dull and inactive, it means the original illness is causing that dullness or inactivity, which is the bacterial infection or the toxemia or whatever. So that's how indirectly you conclude that even when the fever is relatively low, if child is dull, that means fever is not making him dull, toxemia is making him dull, so you extrapolate this is a bacterial infection. So in viral he'll be okay interfebrile, in inflammatory also he'll be okay interfebrile because there's no toxemia, and in malaria also he'll be okay interfebrile. Okay?
So as we discussed, and here's a very long period of fever, after certain time it becomes more important to take history of personal facts, sleep, appetite, weight loss, etc. And also when you're looking at unusual infections, it's important to take history of travel, consumption of uncooked meat or unboiled uncooked meat or unboiled milk, or history of travel and pets. So why am I discussing this is because she has told that this kid was playing with cats, correct? Yes. So any comments on that with respect to prolonged fever? Cat scratch?
A parasitic infestation could be a
Okay.
possibility.
I am not sure whether that is a correct answer or not, but I would have been looking for
Rickettsial infection.
cat scratch.
Rickettsial not
It doesn't
related to
with
cats.
No.
It's related to travel.
So cat
And
scratch disease, as we call it.
Toxoplasma.
Toxoplasma is the second one. Correct.
People staying in villages and a cattle is at home, and then you think of brucella and things like that. So how they are in villages, often the cattle is at home, the gentleman is sitting close to that. Okay, the kambal is not washed for days together. All these things.
So for the complaint of fever, child visited multiple hospitals and child was given IV antibiotics in all the 3 hospitals. The symptoms were not relieved, so the child was brought to our center. And during the hospital stay, at our center also child had continuous fever, high grade, which were documented with 3 to 4 spikes per day.
yeah, this is done. Na? So what is your provisional diagnosis?
So this is a 1 year, 11-month-old girl, second by birth order, born out of non-consanguineous marriage, who was birth and developmentally normal, immunized till date, brought with complaints of prolonged fever since 1.5 months, case of pyrexia of unknown origin to rule out infectious etiologies like tuberculosis or brucellosis, enteric, inflammatory etiology or some underlying malignancy. Could be there. Examination.
Go ahead, examination findings.
I think
I would,
all of those things hold true. What we could have got some more information is antibiotics were given. Possibly antibiotics were started right to begin with, maybe on the first visit, maybe on the first day itself, which has made a difference. But suppose we had a story of 2-3 days without an antibiotic, then we could have made up much more. Otherwise, all those things stay. But it's a long list. We have almost looked at. What I want to drive it at, if a history cannot make a small differential diagnosis, then we should back and say, could we have asked something more? This is what we have theoretically discussed. Okay, we discussed all bacterial infection. You can talk about EB virus, CMV virus, prolonged viral infections, immunodeficiencies, autoimmune malignancy. These are all the groups. So now we will have to depend on the physical findings only. It's rare that you do not get a small differential diagnosis on a history, and it's always worth an experiment to see whether some more questions could have made us shorten the probable history. But I'm sure there is a limitation. This child is getting so often, parents have been asked the same question again and again, and they may not have remembered many details. So we stay with that. Let's see the...
Just a comment on SOGI. While we know that localization to the joint may occur a little later, by 10th, 11th, 12th day, joint localization not taking place is relatively uncommon. So in the 1.5 month, so far no joint localization puts your SOGI quite down the list. Similarly for enteric fever, 1.5 for reasons which we mentioned. So again, we are shortening the list for possible diagnosis.
On examination, the child was conscious, thin-built, lying comfortably in mother's lap with IV in situ in the left hand. The child was febrile. Pulse rate was 140 per minute, regular, normal in volume, no radial or radiofemoral delay. Peripheral pulses were well felt, central pulses were well felt, extremities were warm. CRT was less than 3 seconds. Respiratory rate of around 26 per minute, regular. Blood pressure was around 92/64, around 58 to 98 centile. Saturation was maintained around 98% on room air. Anthropometry wise, the child falls in moderate acute malnutrition category with weight being 8.36 below -3 standard deviation and weight for height being between -2 to -3 standard deviation. Head to toe examination wise, head normal in size and shape, eyes, ears, nose normal, mouth, oral examination normal, no ulcers, throat was also normal, no lymphadenopathy. Some pallor is present, no icterus, no clubbing. Upper and lower limbs were normal, chest, abdomen, back and spine also normal, genitalia normal. Systemic examination wise, per abdomen inspection, the abdomen was globular, umbilicus inverted in midline, no scars, sinuses, no distended veins. On palpation, soft and non-tender, liver of only 1 centimeter was found, soft in nature, spleen was just palpable. Percussion and auscultation wise, no significant findings. Central nervous system examination, the child was conscious, oriented to time, place, person, higher mental functions being normal, tone being normal in all 4 limbs, power more than 3/5 in all 4 limbs. Reflexes were brisk, bilateral knee and ankle 3+, biceps, triceps and supinator were 2+, bilateral ill-sustained ankle clonus is present, however no motor or sensory involvement, no cerebellar or meningeal signs. Respiratory and cardiovascular system examination was within normal limits. No.
Can you get the child and show us the signs?
What is your comment on spleen just palpable? I thought that's the only positive findings. Spleen palpable is not normal. So let's take that ahead and see whether we can put some of them out or some of them remain. Okay. Yeah, Betty. Any comments on just palpable spleen? First tell me whether it is normal. Could it be normal? Or it's always abnormal?
Sir, in order to the spleen be able to palpate, it should have been enlarged at least twice. So.
Excellent. So we'll take it as abnormal. Okay. So now what's your comment on that abnormal spleen with a long drawn fever? Malaria?
It's chronic malaria.
Leukemia? Okay. Tuberculosis? Enteric? Yeah. So, any comments on that? Let's make a guesswork, because many things may be ruled out, but nothing can be ruled out confidently. Okay, so we'll try something more.
So anybody for seconding for malaria?
Speak out, doesn't matter, isn't it? Even none of us know what this was going to be.
So even the brisk reflexes and the clonus, even the brisk reflexes and clonus is abnormal.
Yeah, we'll come to that. Sir is asking, because of spleen, would you bring in malaria? So I am telling you we won't bring in malaria. Now tell us reasons why we won't bring in malaria.
In malaria, spleen will be firm and not soft. More than just palpable.
What else?
It won't be mild splenomegaly, sir.
That's what she also said.
Hepatomegaly should.
Recurrent malaria would have had enlarging spleen. Why just palpable spleen? Several episodes of malaria? Okay. So that looks unlikely. Okay. So we'll leave that for a while. Enteric? Yes. That is another. Recurrent malaria would have had pallor also, which you have not mentioned. No pallor.
Some pallor.
What about enteric? Partially treated, just palpable spleen, getting better, not better.
So enteric would have had hepatomegaly more than splenomegaly.
Fine. Okay, abdominal distension, because it's an intestinal disease. There is a vague intestinal abdominal distension, hepatomegaly, so less likely. TB?
Could be, sir. Possible, sir.
So TB of the spleen.
So in this case, I would think disseminated.
So disseminated before spleen or with spleen, what should you have?
CNS. Sir, the manifestation of the reflexes being...
So CNS TB is not part of disseminated TB, no? Disseminated
with
TB?
hepatosplenomegaly
So that's what I'm saying. Where's the hepatomegaly?
Dissemination occurs through bloodstream or lymphatics. So then those organs must get enlarged also, not just the spleen. So that's unlikely. So malaria, enteric, tuberculosis, less likely. Brucellosis? Some thoughts. See, today in medicine, there is a wide spectrum of presentation of every disease. So whatever we are trying to say is what is most commonly expected, but not necessarily always there. So brucella is typically a multiple organ abscesses. Okay. So again, hepatosplenomegaly, okay. So less likely or unlikely. So almost we are throwing out infections in this child. What about the esophageal spleen? Yes. Esophageal is a spleen, the lymph nodes. What about esophageal?
Sir, as sir said, joint involvement should have come to know.
So we diagnose it as malignancy now, because we have ruled out all that. So what malignancy?
There will be hard spleen in malignancy. Not necessary, depends on duration, etc. And in children, malignancy often is short. So leukemias are short and fast, whereas lymphomas may go on for a longer time. So hard and soft will depend on that.
Which malignancies in pediatric practice come with fever? So we'll discuss those and see whether we fit in any of them.
Lymphomas.
Fine. So one is leukemia lymphomas. Okay, that's one. Any other? And the only other which presents with long-term fever is neuroblastoma. And neuroblastoma is hiding clinically, sometimes even on investigations. Okay, imaging. Could it be a neuroblastoma? Long-drawn fever, child is not doing well, antibiotics are not working, you have some evidence, something. A neuroblastoma is typically seen in younger children, so this child is young, but if it goes on without diagnosis, often the bone, skull, these are secondaries. That have not happened. So less common malignancy that comes with fever, but often picked up by a nodule somewhere on the skull or some bony lesion. That is not happening. So that's unlikely. So then we are left with only leukemia and lymphoma. But there is no lymph nodes. So would you say no lymphoma? And only stay with leukemia?
So what are the different presentations of lymphoma?
Night sweats and weight loss.
No, in terms of, sir is saying no lymph nodes. So can you have lymphoma?
Pain.
Yeah, so you can have hidden lymph nodes which are not clinically visible.
But where hidden? Hidden and asymptomatic. If they were in the chest, he would have started coughing, some compressive lesion. So where is this hidden?
So abdomen, if the abdominal lymph nodes are involved then.
But abdominal lymph node would have gone on increasing. No, it would have come as a lump. Is there any other place in the abdomen where there is a lymphoid tissue? One is lymph nodes, yes. Even intestine. Intestine is lymph node. So, but we are just trying to see how hidden things come up. But as of now, we have no clear diagnosis at all. So, would somebody first palpate a spleen and say, is it splenomegaly?
In the discussion, one small point is treated leukemias are going to be little difficult. If by chance this particular treated means wrongly treated. The child has been on steroid for some time, then it is going to put us in difficulty. But 3 admissions and every time somebody has given steroids to this particular child is less likely. 1 or 2 admissions steroid might have been easily given either at the hospital level or at the family physician's level. So keep that partially treated is going to change the picture, and our logic may fall short here.
Just few comments from Dr. Palniraman on the chat. He said Indian tick typhus can happen with pets, not necessarily cats itself. Playing in dirty water in ponds in countryside can lead to melioidosis. And in this case, he says brucellosis still remains on the card. Just his comments to share with all of you.
Could somebody just quickly palpate the abdomen without disturbing the child?
Could it be HLH?
So my concept of HLH is a sick child, and it's like a progressive disease. This child is not showing any major progress in any other way.
So when we said about malignancy and fevers, we talked about these acute malignancies which sir said. But sometimes we like to call it slow malignancies. So slow malignancies means your LCH or myeloproliferative disorders or pre-leukemic conditions where it does not classically fit into it, but even they can have fever smoldering for a long time till you get some particular findings little later.
Come, some volunteer to check the spleen, liver spleen.
Inspection. Tell us what you heard.
I'll hold the mic.
Yes. On inspection, abdomen looks normal, sir. No distension. Umbilicus is normal. There are no scar marks. No dilated veins. Flanks is normal, sir. Not full.
Do you think umbilicus looks a little lower down instead of being in the center? पैर सीधा करो बहन जी, एक मिनट, पैर सीधा करो.
A bit lower down.
Looks
sir.
lower down. What does it mean?
Upper abdominal distension, maybe
And
there
what
was some
upper abdomen means what? Spleen, liver, or both?
Maybe both.
Often liver first,
Or liver.
maybe liver only or both. Okay, now palpate.
Yes.
But you said abdomen is not distended.
Yes, sir.
So here is abdomen not distended, but the umbilicus seems to be a
Umbilicus is
little lower down. So we need to confirm which is right, right?
The child is going to cry. You have to examine when the child is crying.
Both, sir. I could not feel both, sir. Liver and spleen.
What is your interpretation of those brisk reflexes? What could they be?
CNS infection.
Hey, don't say CNS infection. Let's first, so every sign means something and then you further go to what it means. So the brisk reflexes means pyramidal tract involvement. What does it mean? What do you think? What do you all think? Should
Spleen is definitely palpable, 1 centimeter or little more, and liver is also not just 1 centimeter. It's more than 2.5 to 3 centimeters. Right lobe is palpable, left lobe is also palpable. So there is, you can say, for practical purpose of discussion, hepatosplenomegaly. It's not tender though. When you palpate, you must put your hand there and quietly wait for the child to take a deep breath. When the child takes a deep breath, then the abdominal muscles are relaxed, and that's the time where you short time you have to go down and come back, and then you can feel the liver as well as the spleen.
I think if you were sure that the umbilicus was little down, then you must find some hepatomegaly also. Okay, it's not easy. Many times he's crying small. Okay, but I want to know, where just now he's crying, how sick was he looking at? Is he a sick looking child or a fairly happy child?
It's not toxic
I mean,
looking,
these are
but,
subjective things. You may be fine but still unhappy. So, happy and not sick, etc. is not all that. But what's your impression?
the child was not toxic looking, but like.
Okay. So possibly he was not.
Is he playful in the ward?
Yes, sir. In the interfebrile period, she is playing with the mother, obviously not with us, but
She's playing.
playful.
So at the end of that, we are only sure that there is possibly a hepatosplenomegaly. Okay, for our discussion. And then we go back to all those things and everything looks possible. We said no liver, so we almost got out of everything. But now we keep on that. If there has been no steroids given at all, no blood transfusion at all, then possibly there has been no intervention unnecessarily to hide leukemia. So then leukemia is out, lymphoma is out, which leaves a void, SOGI looks unlikely. So then we come back to infections. See how we keep on changing our impression just by those findings, right? So possibly partially treated infections, which one we will not be able to pick up just now on that. But something that is not making the child very toxic, which means some antibiotics have been working, so it must be a very drug sensitive infection and not getting cleared totally, right?
You said that, so I was talking about the brisk jerks. So what do they mean?
So meningismus could have, at the time of fever, if we are checking for the reflex, so it can present
Okay,
as.
so at the time of fever, the reflexes could be brisk. Anything else?
Only lower limb reflexes will become brisk, or all reflexes will become brisk with fever? Sorry, I'm not being funny, but just asking a question.
What else?
No, you're right. See, it's always easier to examine the knee and the ankle jerks, so that we tend to appreciate better whether they are brisk or not. Honestly, in a 15-month-old child, it's not always easy to say that the biceps and the triceps or supinator is brisk. So I take your point on that. But when would you say a brisk reflex is abnormal brisk reflex? That is what Dr. Rajesh is asking.
Sir, clonus and plantar, two things. Plantar
Very good.
extensor.
Excellent. So tone also? Tone?
Yes.
Clonus and plantar. So if there are associated pyramidal tract signs, if there is asymmetry between the two sides, then it becomes even more important.
So symmetrical can often have non-specific causes like you discussed just now. And one more thing to keep in mind is raised ICP, but then you have to correlate it with the behavior and other things of the child, which is not correlating here. So the child is not behaving like a raised ICP child.
And hydrocephalus in early stage can only present with mild pyramidal tract signs, predominantly in the lower limbs because of the stretching of the paraventricular fibers.
And I think 2+ and 3+ are nearly same. If there was a much different, that I was not able to easily get the reflexes in the upper limb, but yes, they were present and lower limbs were flinging, then I would have said it was that. But rightly, they are not dependent. For example, a malnutrition itself can have some myelopathy, okay, a little breast jerk, so many, but they are symmetrical. Here we will call it symmetrically present jerks, okay, which are not pyramidal. Any investigation done.
And there is no neck stiffness, right? Somebody said meningism.
Infections
so
and relatively uncommon infections should be our one of the first thing. Because we don't know so many uncommon infections.
Serial investigations were done from outside. CBC trend on 1st January was 8.3, hemoglobin with counts of 14,000, platelet of 5 lakh, and serially...
We missed UTI. 10, 12 per cell, bladder is thick. Oh, we missed the UTI. Yeah, it's there. Look at that abdomen USG, minimal bladder thickness. Male child.
Female.
So presence of pus cells only suggests pyuria until unless there are complaints like
10
this.
and above is significant, no? And 10 to 12 is more significant. Yeah, sonography is also positive. What else do you want? This is UTI.
That can be just due to fever.
So at best, pus cells could be even out of any fever. 10 to 12 is not very abnormal. And that bladder, minimal thickness. Okay. When you say mildly congested throat, you are telling the examiner it may not be congested at all. And if he says, where is congestion? I said, no, mild. Okay. And when you say occasional crepes, I have always asked this question, which was the occasion? Okay. So, minimal. So, forget about that. Okay.
So, UTI should have responded to medications in the 3 admissions.
What you would have said is that if this was UTI for any reason and untreated, coming so early, must be due to some obstructive uropathy. The child would have gone into sepsis also. Okay. Or a renal failure, repeated renal scarring. Okay. So all that is unless. So this is not evidence of UTI.
Just interpret CBC, forget everything else. That perhaps gives us a clue.
Show the CBC, the comparative pehle wala.
Definitely abscess, no. 14,000, 35,000, all abscesses only. No? Rising count with rising dash dash. Rising platelets. And maybe even if it was done, neutrophils predominant.
From our side, this was the CBC on presentation with neutro predominant.
Yeah. So, while it may mimic a bacterial infection, with such a rising count, bacterial infection, definitely it would have localized. Platelets are also rising. So, what is the diagnosis? Pardon me?
Could have history of steroid intake.
Steroid induced.
Increasing counts with increasing platelets.
Platelets are also rising. So, rising count with neutrophilic predominance with rising platelets, where do you see commonly?
So severe inflammation.
Inflammatory disorder.
Yeah.
So we come back from infection again back to inflammation or infection and inflammation. But primary infection looks less likely with such rising counts and even platelets going up. Hematological, so unlikely the platelets will not rise in any of those malignancies. This is particularly seen in SOGIA or other malignancies, other immunological disorder. Here we have ruled out SOGI for all practical purposes. But I think this is in favor of immunological.
I think when the total counts are going up and down, my interpretation gets little difficult. If it's a persistent bacterial infection, for example, the previous slide also, in between a little dip again, now you have shown much lower. So that possibly will have to be not explained on a continuous disease going on. Okay. Platelets could be partly iron deficiency as well at this age. Okay. And therefore, some platelets are increased because of that. Again there, it's not a consistently rising. Okay, 3 to 5 to 7 to 10, yes. But sometimes a little less, sometimes a little more. All these counts are technologically not so easy to depend on. So to that extent, yes, interpretations are right. Higher the count, higher the thing. Again, we have not been told earlier chart whether it's polys or lymphos. But now you have, okay, nothing looks.
Yeah, but even this, just because neutros are more than lymphos, you don't call it neutro predominant. It's 52 and 40, which is like nothing. Right? Okay. Go on.
Yeah, 8 lakhs and now back to 4 lakhs. Our hospital report is 4 lakhs.
Go on.
These investigations have only been done. Urine RM in this admission was within normal limits. USG, abdo plus pelvis also within normal limit. 2D NAD Cox workup was also done, which is negative. Vidal was done, which was negative. Extended Vidal had wheel Felix OX2 titer of 1:80, which is not significant. Lumbar puncture was done, and CSF studies was also lympho 1 cell, protein 15 and sugar of 68. A CT has been done for the child and the report is awaited. CT thorax plus abdo plus pelvis.
I thought you had written HRCT normal in the previous
that was
one.
outside investigation.
Oh, okay. Plain and contrast? Or
Yeah,
just plain and
contrast.
That's it?
Yes.
CT brain was normal, done outside.
Fine. I think we can...
So now if it's a PO going on for a long time, what more tests would you do? So far we have no idea what's happening. Okay. So what more tests?
ANA.
Why?
Brucella serology. Okay. Bone marrow aspiration.
Sir, scopy, there is no history of any alteration in the bowel habits, but even inflammatory bowel disease we can keep.
So inflammatory bowel disease will not present with fever alone for so long, 1.5 months, right?
Yes, sir.
ESR is 97 at one point.
Yes, sir, is still high here.
Yes, so now also it is 66.
66.
Could it
Blood
be drug?
cultures are negative.
Could it be drug fever? And we should stop all the drugs and see. So what's the treatment you are trying?
Now the child is on meropenem.
We should be ready to decide after all antibiotics are tried and fever continues, what is next? So possibly it's a good idea to stop everything. Also because there is no danger in stopping. He looks comfortable, he looks stable. And if you stop, two things will happen. Either fever may disappear completely, we don't know why, or something may come up, either on investigations or clinical examination. I think whenever there is a long drawn fever of unknown origin and a child is stable, one good thing is to stop everything. Okay. And whenever you don't know, there are 3 roads coming at a junction. If you don't know, don't you stop and think and ask somebody else? But what do if you are in a hurry? You take one of the roads? No, if you are in a hurry, more the reason you should wait and find out. Otherwise you go wrong like this. So I would say stop everything and then look at what's happening. Right?
Okay. I think we'll stop here. And any questions or any other point anyone wants to make? Nothing from the chat. So we now get on to the second part of today's class, which is an approach to inborn errors of metabolism by Amdekar sir.
I think like last time, I'm going to give an overview of how I remember all these complicated things. And if I can remember at my age, you can easily know it well. Okay. And therefore I thought I'll share what way I remember. It may not be complete, but it's complete as far as the clinical, practical application is concerned. And that's the reason why we are choosing types of discussion after the case to kind of get idea of how one can make simplified approach of difficult problems, right? Now I think one thing you must know that what is this metabolic abnormalities? Normally if a product A has to be converted into B and B into C, you need the enzymes. And if A to B, that enzyme is lacking, it may develop into D. That is an abnormal metabolite. And A to B went well, but if B to C, that enzyme is defective, you end up with E. And that D and E are troublesome because they are abnormal metabolites. And that is exactly how inborn error of metabolism works. What about the types? There are different ways of discussing types. One could say, is it protein, is it carbohydrate, lipids, vitamins, minerals? But that doesn't help a clinician. This kind of a thing helps the clinician. Is it intoxicating? Okay. What does it mean? That abnormal metabolite is very toxic. And what does it do? It often presents acutely as well. And it may present, as I've said, often triggered by infection, vomiting, diarrhea, drowsiness, seizure, convulsion, whatever. And if it is triggered by infection, then you start thinking about infection only. So that is the typical intolerance. But similar thing happens also when the metabolite, abnormal metabolite is energy deficient. So if it's energy deficient, largely again a crisis occurs, and this crisis is typically hypoglycemic, seizures, drowsiness, coma. Again, it simulates the first one. Okay, but these hypoglycemic manifestations are typical of CNS manifestation, whereas the first one are even often GI and often vomiting, but also sometimes diarrhea, etc. So small differences might make us clinically suspect that is one of the first two. But what about the other two? Storage typically, going on slowly, deteriorating, abdominal distension, maybe neurological, whatever. And then common neurodegenerative, where the whole story goes on slowly. So you have two types which come acutely, often as a metabolic crisis, looks like infections, and then the other two which come slowly, whatever the presentation. And I think this is the major difference between the two types of inborn error of metabolism. This is clinical application to begin with. What next do we want to know? We want to know the difference in organ involvement. The most common involvement is hepatic. And then you have tyrosinemia, for example. You have a fatty oxidation defect. You have a glycogen storage. You have a peroxisomal, like AD, Zellweger-Refson. You have a bile metabolic defect like a PFAC. So you need to fit in one of these, and the presentation would be like a hepatic disease. But again, the differences are majority of these disorders come up pretty early in childhood, infancy often, and that's not the time where you land up with infections. And therefore in the previous slide I had mentioned to you that if this is the type, you start looking at where does it fit in. If it's an acute onset, then you know that it is possibly one of the two. Okay, but you can see how they can almost look like infections many times. But the age may be different, the progression may be different, epidemiology is not fitting in, and that's where hepatic involvement, you start looking at these few types. Again, there would be difference, like fatty acid oxidation, you have a hypoglycemia, a tyrosine may have a liver kidney involvement also, besides also the skin involvement. So this combination of syndromic things will add further to make the diagnosis clinically to some extent narrower. So this is one area that we need to look at, whether my presentation of an inborn metabolism is primarily a hepatic presentation. What about the cardiac presentation? Again, few things come into play. I have put down few common things that present as a cardiac manifestation. And what are they looking like? Acute myocarditis. Okay. And often we diagnose them as an acute myocarditis and we call it viral. But viral myocarditis is a diagnosis of when we don't know what it is. And it could be one of these. Again, keeping in mind an undiagnosed cardiac, acute onset cardiac disease, we might have to think more often today than just a viral myocarditis, and it could be one of these. And again, you look carefully, some of them will have a liver and spleen, but manifestation could be an acute cardiac problem. So acute breathlessness, cardiac failure, etc. That's another organ that you watch carefully for. And of course the third organ we know very well, and in one of the times we will also discuss how clinically to arrive at a probable diagnosis of a neurodegenerative disorder. But many of them are the inborn errors of metabolism, and therefore we will not discuss those details, but I've just put some of those two. Again, a neurodegenerative are two types clearly, one which has a grey matter involvement to begin with, and one which has a white matter involvement to begin with. Of course, both overlap very soon, and then you have the typical PKU or an MSUD, and then you have a Tay-Sachs, Sandoff, etc., those other ones. Again, an age of onset of neurodegenerative disorders makes a lot of sense. The grey matter disorders often come rather early, and the white matter disorders come a little later in an infancy, maybe 4-6 months onwards. So these are a rough kind of a situation. The grey matter typically come with MR without white matter symptoms, that means no stiffness and often seizure, whereas the white matter one has no seizure but often comes with some change in tone. So we know that. But when we see them a little later, they are all overlapping. And again, like we discussed in this fever case, how does the story start becomes very important to differentiate between white and grey matter. And then there are many neurodegenerative disorders where you have a skin manifestation, where you have a peripheral neuropathy, where you have either a microcephaly or a megaloencephaly, the macrocephaly, like Tay-Sachs, for example, Canavan's, Alexander, okay, or MLD. Now these are people who present with a large macrocephaly. So each one of these points further add on, but we might discuss in one of the sessions how to clinically approach a neurodegenerative disorder. But these are the three major organs which take the brunt of an inborn error of metabolism. Yes? But what is more important is that every time when you look at that, how do you clinically suspect them? We have seen clearly the type of presentation and the organ involvement. Two put together, but how do we suspect that? There are vague non-specific symptoms. For example, if you have a neurological infection, intracranial infection, then the story starts with high fever. But many of these are triggered by fever. So again the problem comes. But if there is a meningitis, okay, or encephalitis, typical meningitis has an irritability, okay, and then gradual drowsiness. Encephalitis may be drowsiness and seizure, which may look like an inborn error. So we may have to look at carefully, is this child at risk of a viral infection? For example, you have a 3-month-old. He's at home, he's well breastfed, there is nobody in the family who has a viral infection, and he comes with what looks like a viral encephalitis, then that's not the situation of getting a viral infection. Because why should he have a viral infection coming when nobody at home has any fever, and this child is 3 months old, well breastfed? So such situation would differentiate all this, but then you look at very vague symptoms, poor feeding, lethargy, vomiting, seizure, coma, sepsis-like. Okay. Many times the inborn rheumatism is diagnosed wrongly as sepsis because you have fever and you have something happening further. Okay. And that is how there's delayed development, of course, we said, at which time you look at the urine odor, you look at the skin color, you look at jaundice, cardiac symptoms, etc. For example, you have a child with a neurological manifestation but also has a large liver, then gives you an idea that no, something different is happening. So that is the symptomatology. What are the signs? As I said, micro or macrocephaly is an important parameter, but many may have a normal skull circumference as well. Then white and grey matter abnormality. There may be other neurological symptoms. For example, a child comes with acute encephalopathy. Okay, you may not be able to pick up ataxia, but there may be a peripheral neuritis, there may be a cataract, there may be a cherry red spots. So gives you some idea about, of course, coarse faces, and as I said, skin manifestation, organomegaly, cardiac manifestation, all put together could. But what is the bottom line, most important? Rule out these three conditions every time. Okay. For example, a child comes with acute neurological problem. I want to rule out trauma, infection, and congenital malformation. Child comes with hepatomegaly and jaundice. I want to rule out infection and congenital malformation, choledochosis, biliary atresia, whatever. If those things are easy to rule out clinically or by simple investigation, you know you are dealing with an inborn error of metabolism. And I think make this a routine that if it doesn't fit in one of these three as an etiology, then what looks like neurological, hepatic, cardiac, etc. might in fact be an inborn error of metabolism. This is how you clinically suspect. Once you clinically suspect this, you have a screening test. Now there are multiple ways of doing screening tests, but what I am presenting looks very simple to me and very easy to understand. What do I do first really? I look at urine sugar and ketones. Okay, because hypoglycemia is a common thing. You have an amino acidopathy, organic acid. Okay, you must get the urine, ketones and sugar. Well, you may do even urine electrolytes, etc., but that's not so important as a screening test. But screening test, yes, the sugar and the ketones. And we will see what's important of it. Then I want to do serum ammonia. And along with ammonia, anion gap. Two together can differentiate many conditions. For example, if ammonia is very high and it's a normal anion gap, or you are on a urea cycle defect. If ammonia is still high, may not be so high as in urea cycle, but pretty high, but anion gap is high with metabolic acidosis, you are really looking at an organic aciduria. And if it is very minimally increased, then you have a fatty acid oxidation defect, which has also hypoglycemia. So ammonia and anion gap becomes a very important thing to fish out these things. And if ammonia is normal and anion gap is normal, then you have an amino acidopathy or galactosemia. Then you add on other things. Or do you have a liver, do you have a cataract, whatever. That's the next thing. But we are looking at a screening test, how they could differentiate easily common things first. Then of course you do blood sugar, because hypoglycemia is one of the common manifestation of multiple types of enzyme deficiencies, and we'll discuss about hypoglycemia in the next 5 minutes. But we'll also do ABG, because we said that even metabolic acidosis is a common accompaniment. So these are the screening tests: ammonia, anion gap, blood sugar, ABG, and the urine sugar and ketones. This almost gives you a group diagnosis. Then of course further special investigations might throw a final diagnosis. Having said this, because hypoglycemia is a common manifestation of some of these inborn error of metabolism, let's talk a bit more about hypoglycemia in particular. But before that, management. How do you manage IEM really? Okay, most important is many of them come as an acute onset crisis, and you have to save them at that time, whatever the cause. And what saves them most commonly is stop oral feeds, because that's the cause. And I recall at times when a few weeks old child comes with an acute encephalopathy, gets admitted, they send septic screen, CSF, all that, they put on IV, and the fellow wakes up after 24 hours. Looks fine, because he is not consuming anything more, nothing abnormal metabolite is coming up. Starvation is one area. And then they look fine. Your tests come out normal. Okay, no sepsis, no infection. You observe, he looks all right. You send him home, he starts feeding again, and he comes back again. So one of the managements is, of course, stop everything, but they come in crisis, so nobody is going to feed them. Point is, if mere no feeds and doing something else makes a quick improvement, you have a metabolic disorder. Infection don't improve like that. So metabolic and immune disorders come up suddenly and may also improve suddenly and may recur. So that's one important thing to look at. What's the initial management? Like any critically ill child. So when you get a critically ill child and it doesn't fit in, infection, trauma, congenital malformation don't come with acute crisis, then you start thinking about inborn error of metabolism. And then of course you know all this, you treat shock, do airway, breathing, circulation, correct hypoglycemia, acidosis, they are common, hyperammonemia. Sometimes you have to use a drug or even hemodialysis or peritoneal dialysis for ammonia. And then no oral feeds, most important. Many of them have a kind of a shock and they need more, but if you flush them out with little higher volume of IV fluids, then whatever the metabolite, the poison, can go out of the urine, and that may be another way to wash out that kind of a toxin, and that is what is often done. Once this is done, then comes the long-term management, and that depends on what the final diagnosis is. And really, you have a diet modification, some have a pharmacotherapy, organ transplantation, bone marrow transplantation, enzyme replacement therapy is now available, though costly, and finally the gene therapy. So this is the overall management. Just last two slides on what is hypoglycemia, because this is not uncommon in any acute condition, be it whatever the cause. And just again the basics of what is hypoglycemia. When you have a demand for oxygen and a demand for glucose and energy is met with, okay, that means I have had enough. Then the remaining glucose is converted into glycogen by insulin. This is the way we have extra glucose stored as glycogen, and then this same pyruvate in turn can form glucose and fatty acids. Now glucose is also formed from other sources. You have a glycerol, you have a lactate, certain amino acids are sources of sugar as well. So if you understand this, you also will understand what are the common groups of causes of hypoglycemia. And then you have a glycogen which is stored. The glycogenolysis provides glucose, but that's only for a few hours. It cannot go on for a long time, and if you don't have enough and you go on hypoglycemic more, then you will have to really glucose from other sources, and that's how the brain picks it up from ketones, and that's the importance of doing urine ketones as well. Now this is the basic that I thought you need to look at, and therefore when there is a prolonged fasting, the brain derives energy from ketone bodies, and that is possible with fatty acid oxidation. Now if you have understood this, now you can understand 4 groups of causes of hypoglycemia, and you have to fit them in one of these 4 groups. So let's look at these 4 groups. First is a hyperinsulinism. Okay, either it could be a pancreatic tumor or any of these hormonal deficiency could also have hypoglycemia, hypothyroid, hypopituitary, and of course adrenal. So when you have a hyperinsulinism, it's not only the pancreas, but any other endocrines also come into play. Then of course you have a failure of glycogenolysis. I have glycogen, but it's not getting into glucose. So you have a glycogen storage disorders of all kinds. Then you have a failure of neoglucogenesis. No, new glucose is not getting formed, as happens in galactosemia or an MSUD. And finally, you cannot break down fatty acids. Therefore, fatty acid oxidation defect. You fit in any hypoglycemia in these two, be it at any age. Of course, starving, long time, etc. But then you have a natural way to take care of it. And if you look at these then first step in evaluation is urine for ketones. Okay, for any hypoglycemia, you do urine for ketones. And if ketone is negative, you have the first and the last cause, hyperinsulinism or a fatty acid oxidation defect. And straight away you look at one over the other, right? And if it is positive, then look at lactate. If high lactate, you have a glycogen storage disease and or the FAO defect, and if it's normal, then you have MSUD. I've just taken common condition that you might have seen occasionally or heard, and out of the rare inborn error of metabolism, these are the common ones. And I thought what we have learned today is hypoglycemia, hyperammonemia, metabolic acidosis, and iron gap. These are the four things that you play up with in evaluation, and in hypoglycemia you have further groupings of this kind, right? I thought this becomes very, very simple, and now if you kind of revise this 3-4 times, you may wrongly, though confidently, feel you have understood inborn error of metabolism totally. I don't mean that at all, but this is all that I can grasp, and this is all that I can need. The rest is laboratory. But instead what do? You do all the tests. Okay. I thought this is the clinical approach that may be of use to us in writing a theory paper. Now if you write this way, almost all your examiners are experienced people, and what is experience you know. Experience is defined as making the same mistake again and again with increasing confidence. So for them, understanding what you write or what you say is not easy. You have to simplify it. And these are, I thought, simplification of all this. If you look at this, I'm sure you must have felt for a while it's so easy. And my whole job was exactly to make it so easy, because then you will remember that what looks easy is never easy. That's why we need specialists, right? Thank you.
Though made to look so easy, as Sir always does, it requires pondering after going home. We must do the same homework, Sir, as you have done, and go through all that you said and rethink and think. Then it will... first slide I thought was important for us, when to suspect. And then once you suspect, then you think on those lines. Otherwise you go the wrong way, searching for infections. Thank you very much, sir.
Any questions, or anybody wants to ask any difficulty?
If you have any suggestions of what topics might interest you, which are little difficult to grasp and more than grasp, remember. Okay. I know one of the classical textbooks of pediatrics, not Nelson, has the last chapter, what you forget to remember. That's the title of that last chapter, what you forget to remember. Okay, that means we even forget to remember. I don't recall the author's name, you may remember it. But
at moment, no.
But the last chapter is what you forget to remember. Okay, I thought it was an interesting topic. So if you have any suggestion, for example, renal tubular function, not easy to pick up, ambiguous genitalia, okay, confusing, not difficult, but we don't see them more often. If you have any more suggestion, I'm sure. I just filled in because we are trying to get our other teachers to kind of get on the web through their home. So we are just arranging that. By next time we will almost have it. But if you have any suggestion, please tell us of whatever kind. Let him know that we will certainly try to make it simple, right?
So thank you. With that, we'll end today's class, and we meet again on next Thursday at 6 p.m. Thank you to all our online viewers and our online faculty for giving their inputs. Thank you.
Just tell us the diagnosis next time, if you have.